So good afternoon, everybody, and welcome to the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our mission statement is listed here for those of you who would like to take a look at that. We can move on to the next slide. So as we go ahead and begin here, if you could make sure that your microphone is muted. I know that our speaker has mentioned, though, that if you do have a question or a comment, you're more than welcome to join in during the presentation. Also, I'll be keeping an eye on the chat box, so feel free to put questions or comments there as well. But if you could, please remain attentive and engaged in this session. And towards the end, I'll be putting in the evaluation link if you can help us provide some feedback for our speaker. Next slide. So for those of you who are claiming CME credit, this is the code for today's session. It is listed there. Just a big reminder, I'll go over some other instructions here in just a moment for those who may be new to this. But make sure that you do register before midnight tonight so that you can get that credit. That's the main thing we want to make sure on this slide here. So if you have not yet registered, please make sure that you send your email address to the number listed there, the toll-free number. Once you've done that, you should get a message that says that you have registered successfully. Then from that point forward, you just need to text the activity code for today, which is listed here. And you'll text attend and the code to the same toll-free number. But if you have any questions, please feel free to reach out to me or to the CME office. Next slide. Also, if you are claiming those credits, make sure that you do check your CME transcript from time to time. You can visit the CME website listed there. But if you have questions or any issues, please feel free to reach out to their office, or you can reach out to me as well. Next slide. Also, by way of reminder, we just want to make sure that those who are AAFP members are aware that you can also get credits for viewing this presentation through the AAFP. But any questions, again, just reach out to myself or the AAFP. Next slide. Also, we want to make sure that we do mention that we do try to address these nationally established physician core competencies that you see listed here. Next slide. And we also want to mention that Dr. Dixon has no financial relationships with ineligible companies to disclose. So she is going to be speaking with us today on infectious disease in the news. She's going to be talking about monkeypox, so I'll let her go ahead and take it from here.
Thank you very much, Nicole. It's really nice to be here with all of you. I figured that everybody is probably sick of COVID, so I wanted to discuss kind of some other interesting things going on in the ID world. This can be interactive. If y'all have questions, you can feel free to jump on. I did figure out how to look at the chat, so I can see the chat, and I'll try to kind of pan over to that every once in a while to answer any questions as we go along. But I'm Danielle Dixon. I'm one of the ID faculty. I did my fellowship here in infectious disease, and I finished in 2021. And then before that, I did my residency at Baylor in Dallas, and I did my med school at TCOM. So I'm a pretty steadfast Texan in all those events. So I'm going to turn my camera off so we can get started. And then that way it's a little bit less distracting and you can kind of minimize, but I've got the chat up and we'll go ahead and get started. So our objective today is to talk about monkeypox, kind of summarizing the history and the epidemiology and pathophysiology, kind of talk about clinical signs and symptoms, presentation of monkeypox. I'll go over differential diagnosis of acute vesicular lesions. I'm going to talk about the current state of the monkeypox outbreak, as well as talking about treatment options, vaccine management, and kind of just to give y'all an overview of what to do if you're worried about somebody that you're seeing in the clinic or the ER or inpatient service that could have monkeypox. So all these, any good Grand Rounds case, I think, starts with a case. So this is a 26-year-old male who presents to your primary care clinic with a 5-day history of headache, fever, swelling in the groin, and 3 days of rash. He doesn't have any past medical history, but he's currently taking PrEP with daily intracidabine and tenofovir disoproxil fumarate or Truvada, and he doesn't have any recent travel history. He identifies as gay, reports recent history of unprotected oral and anal sex with multiple male partners via dating apps. On exam, he's febrile, and he's got cervical and inguinal lymphadenopathy, and you see a vesicular rash on his trunk, extremities, and groin, and all of them are in the same stage of development. Here's a quick photo of the rash that is including his palms and soles. So if you missed the beginning, maybe this will be a difficult question, but what is the most likely causative agent? Is it syphilis, smallpox, varicella, or monkeypox? I'm looking at the chat. I've got a vote for D. Anybody else? Well, so y'all already know everything, so we can just stop the presentation. Just kidding. Yeah, so it is monkeypox. So what is monkeypox? So it's a viral zoonotic infection, and it was first detected in captive Asiatic monkeys in 1958. So basically there were some monkeys that were shipped from Singapore to a Denmark research facility. And they, once they arrived there, they had this exanthem of rash that they developed. The first human case, however, was noticed in 1970, and it was in the Democratic Republic of the Congo. The virus was isolated from a child that was suspected to have smallpox. And up until recently, this infection only naturally occurred in Africa, especially in rural areas. And in the United States or worldwide, it was more seen related to travel or due to global commerce. And an important thing to note is that monkeypox is kind of a misnomer, and there is discussion about how we should change the name of this virus or this infection. But actually, probably the most important reservoir for this is in rodents. So squirrels, giant pouch rats, we'll kind of talk about a little bit about the different rodents. But monkeys seem to be kind of an accidental host, just as humans are, but the reservoir for the virus seems to be in rodents. This is a map just showing the countries that are reporting human monkeypox cases up until 2019. So this is really kind of the area that's considered the endemic area of monkeypox. These are a couple of, if you start reading about monkeypox, you'll start reading all these things about all these different squirrels, rodents, mice, and things. So I just compiled a couple of pictures. I kept hearing about rope squirrel, and rope squirrel is different from squirrel on a rope. So these are completely different squirrel animals. This elephant shrew, which I had never even heard of, but it just looks like it's spewing droplets here. And believe it or not, people do keep Gambian pouch rats as pets. And even this one was in an article where they kind of trained it to detect tuberculosis. So yes, this is like a real thing. People have these as pets, exotic animals. But unfortunately, these are kind of the reservoirs of this virus. So in addition, monkeypox is one of the 4 orthopox viruses species that's pathogenic to humans. So we all heard of variola major, which is smallpox, and then a strain of smallpox called variola minor. We've also heard of cowpox, and then you kind of brings to mind Edward Jenner and kind of the early days of learning about vaccines and discovering that the milkmaids that had cowpox were immune to smallpox. But infections have been described from the vaccinia virus, which is a modified virus that is actually used for the smallpox vaccine. Cowpox, like we said, buffalo pox, and camelpox. The virus is pretty large. It's 200 to 250 nanometers. It's brick-shaped. It's got a lipoprotein envelope with a linear double-stranded DNA genome, and it really relies on the host ribosomes for mRNA translation. Otherwise, like all the necessary replication, transcription, assembly proteins are all in the genome. And you'll read about that there's 2 genetically distinct strains. So there's the Western African clade and then the Congo Basin or Central African clade. And the Western African clade, which is kind of described as like clade number 2, and they've even subdivided that into 2A and 2B, and it seems to be less virulent. It seems to lack a number of genes present in the Central African strain. And just to say that the 2B, Western clade 2B monkeypox seems to be what's driving this current kind of outbreak. But the Congo Basin or Central African clade is reported more frequently up until recently, and has documented cases of human-to-human transmission and a higher case fatality rate. Here's a picture of pox virus under EM. So you can see it's large, it's got that brick-shaped appearance. And this is another kind of electron microscopy photo which shows these intracellular brick-shaped vaccinia virions with dense central core and outer membrane. So, you know, when we talk about kind of the history of monkeypox, and we're looking kind of more at the sort of recent time period, but the CDC had put out several alerts. This is everything, we'll talk about this prior to May of 2022, but in 2021, there was a travel associated case in Maryland, and the patient had traveled to Nigeria. Another travel related case in July 2021, very high profile kind of outbreak in 2003, where they had confirmed cases from 6 states in the US, so Illinois, Indiana, Kansas, Missouri, Ohio, Wisconsin, and all these patients became ill after they had contact with pet prairie dogs. And that was really the first time monkeypox was reported outside of Africa in terms of that sort of transmission. And a lot of these patients had contact with a sick animal. They had a bite or scratch that broke the skin. They were cleaning the cage or touching the bedding. And then none of these cases were attributed to person-to-person contact. So as a result, the CDC, in conjunction with the public health departments, the FDA, and even the USDA, it developed extensive lab testing, ramped up smallpox vaccine and treatments, came up with some guidance for patients, healthcare providers, even veterinarians and animal handlers. And they started tracking potentially infected animals, investigating human cases, and they put an embargo and prohibition on importing or transportation, sale, or even release into the environment of certain rodents. So they had a pretty robust response. I don't know if anybody remembers that kind of in the news, but that's kind of the main one when we think of monkeypox. And since then, sort of a kind of off the wall board question about prairie dog exposure. So in the United States, and in 2003, we talked about this already. And it was interesting because it was exposure to these West African small mammals that were imported as exotic pets. And they were imported to the United States on April 9th, 2003. There was a shipment of small animals, and they had those Gambian rats, rope squirrels, dormouse from the affected African shipment was actually stored next to the prairie dogs. And then all these patients that had contact with these prairie dogs ended up getting sick. And they were able to isolate the virus and figure it out based on nucleic acid detection. Some other kind of notable cases internationally was in September of 2018, there were 3 cases in the United Kingdom. And the important thing about this was that there were 2 cases that had recent travel, and then they were in the hospital, and then there was one of the healthcare workers that was caring for the patients came down with it. So that was one of the first times that they saw kind of a human-to-human transmission in a healthcare setting. Someone was got in contact with it and came down with it. Other things have been travel-related. Another interesting case series was from May 2021. Family returned to the United Kingdom after traveling to Nigeria. 3 family members got sick, and their timing was day 0, 19, and 33. And as we'll talk about later, the incubation period really upper limit is 21 days. So that day 33 outlier kind of suggested a human-to-human transmission between these family members. And then the rest of these have kind of been like sort of sporadic, sort of travel-related cases. But that brings us to May of 2022, and on May 13th, the WHO recognized that there were cases in countries that were not endemic for monkeypox, and there were these clusters of cases in Portugal, Spain, United Kingdom, and there was no travel or close contact between these cases. The May 7th case, there was recent travel, and then 1 week later, there were 6 additional cases, but there wasn't any travel or close contact between these cases. And then on May 18th, there was a case reported in Massachusetts, and this person had traveled to Canada, so not to an endemic region of the virus. So of course, the WHO and the CDC began tracking cases, and at first there was no established travel links to any endemic areas. And the interesting thing that came out very soon after was that many of these cases, but not exclusively, were in men who have sex with men, and they were seeking care in primary or sexual health clinics. At first, you're kind of thinking like, could this be detection bias? But they really went through these cases looking for travel, specific risk factors, gender, sexual orientation. And at the time, it was really not known if there was any direct connection between the cases. It didn't seem like there was. They kind of made the hypothesis that this might be spreading within certain communities and could be due to close contact. So this is as of October 5th, 2022. There's over 26,000 confirmed cases of monkeypox in the United States. And you can see a lot of the main areas are kind of in the South area, and also including like New York, Pennsylvania, and California. And then I highlighted the number in Texas, which is over 2,300 cases. And that's as of October the 5th. Worldwide, we're seeing over 70,000 cases. And then this kind of map just shows you that you've got this area here that's in blue, all these blue dots, where cases have been reported. Historically, these areas have reported monkeypox, but as you can see, all of these cases in Europe, the United States, South America, these are all places where previously we haven't historically reported monkeypox. Obviously, there's been a change in kind of the pattern of the spread of this illness. So we talked about animal to human transmission, human to human transmission. Unfortunately, this virus can be transmitted via fomites. So like blankets and clothing of people that have open sores and lesions. They can transmit this with their clothing or with blankets. Not so much hard surfaces, but probably is a little more hardy. I remember at the beginning of COVID, everybody was like wiping their groceries with Clorox wipes, and they were, we were really worried about like grocery handles and things like that. And soon it became that with more data, it's really not transmitted that way. But with monkeypox, we do see more of that fomite transmission. It needs to be direct contact, really, and it needs to be, like clothing and things like that from somebody who has active lesions. The virus does cross the placenta, bite or scratch. This was kind of prior to this current, what we knew prior to this current epidemic, but most patients would get it handling wild game or using products from an infected animal. But really this kind of brings into light about like having direct contact with body fluids, skin lesions, even respiratory droplets. But unlike COVID, this seems to be not as transmissible. So you really need to have direct contact with respiratory secretions, and this needs to be like prolonged face-to-face contact or sexual or intimate contact within 6 feet for more than 3 hours without PPE. So it's really more spread with intimate contact rather than just kind of casual contact or even like caring for patients. Your risk is not as high as say with COVID. It is really important to note that like in general, our population has a decreasing herd immunity to orthopox virus because we don't routinely vaccinate for smallpox anymore. And many of us our bodies haven't seen any kind of version of these viruses. So the virus will enter it from any route, really. If you're exposed to respiratory droplets, you've got nose, mouth, skin, replicates at the inoculation site, and then the virus spreads to local lymph nodes. And these patients do become viremic. So you have a transient period where the virus is in the blood. It can seed other organs. The incubation period is really around 7 to 14 days, and the upper limit is at 21 days. But if you've gotten like an animal bite or scratch, it might have a shorter incubation period, especially at the skin level. And a lot of patients will develop prodromal symptoms before they have the rash. And then the other thing that is important to note is that a lot of these patients have a pretty substantial lymphadenopathy, which can help you distinguish that from other causes of rash and from smallpox. And thankfully, this has a lower capacity for human spread versus smallpox. And maybe it depends on kind of like the source of the infection, or the mode of transmission may correlate with severity of the disease. And why I bring up the smallpox over and over again is basically this can be a classic or modified case of smallpox. It may be completely indistinguishable. So patients will have fever, headache, myalgia, they'll be tired, and they have pronounced lymphadenopathy, so submandibular, cervical, or sublingual regions. They can have mucosal lesions. I would say that this is generally true from the outbreak prior to May 2022, but usually the kind of the general rule of thumb was that you had this prodromal symptoms and then like 1 to 3 days after that appearing to have the rash. So, and it would start on the face, it could involve the oropharynx, mucous membranes, and then spreading to other parts of the body. And it can include the palms and soles. So that's why I included that photo from the case, because it's really important that you know that it can affect the palms and soles. And this rash, it really kind of is bothersome because it evolves over like 2 to 4 weeks. In like 1 to 2 day increments, the rash changes from its appearance, and we'll talk about that. And it really is important to know that these patients can get bacterial skin infections, respiratory infections, GI manifestations, and keratitis can be very severe. And the mortality prior to this kind of May outbreak was around 10%. And that's probably more seen with that Congo Basin or Central African strain, and the West African clade virus doesn't seem to have this high of mortality. This is a photo that shows some pretty pronounced cervical or suboccipital lymphadenopathy on this child. So a little bit more about the rash. So it can begin on the face, trunk, spread to other regions, including the palms and soles. It can start at the site of the inoculation. So thinking about if patients have gotten bit or scratched by an infected animal, or in terms of genital or groin lesions. And it progresses through kind of like as these stages. So it starts out as macule, can turn to papules, vesicles, pustules. They can develop umbilication, scabbing, and desquamation. Some people will only just have localized rash at the site of the direct contact. And a lot of times that these will change synchronously, which is different from chickenpox, where you have asynchronous development of the lesions. And these are firm, they're deep-seated, they're 2 to 10 millimeters in size. They've got a pustular phase that happens about 5 to 7 days before these crusts form. And then it crusts and desquamates. And then the condition usually resolves about 3 to 4 weeks after symptom onset in most cases. And the kicker here is that you're still contagious basically throughout this entire time until the crusts fall off of the lesions. So that's like a pretty long period of time to be contagious. When they looked back at the 2003 outbreak, 97% of patients had rash. Many of them had fever, many of them had lymphadenopathy. They described that a few needed hospitalization, so 9 out of 34 patients required hospitalization, and most of them were for like nausea, vomiting, or dysphagia. If you have a lot of oral lesions, you can't hold down fluids, it's painful to eat or drink. There was a patient who had encephalopathy, who had, and also a retropharyngeal abscess. And it's kind of like how at the beginning of COVID, we were kind of looking through like what kind of lab abnormalities could help us kind of decide if this could be related, but really the lab abnormalities are pretty non-specific. You may have abnormal LFTs, elevated LFTs, you may have leukocytosis, thrombocytopenia, hypoalbuminemia, but it's not anything that's going to be a slam dunk to point you towards that. Things to keep in mind about the May 2022 outbreak and what's ongoing now is that some of these patients presented with proctitis. They had lesions in the genital or perianal region alone. They were men who had sex with men and reported sexual or intimate contact. And of course, this is likely to be seen in other communities, not just MSM. And then on June 7th was kind of the first the first Texas case, and this one was travel related and was seen in Dallas County. And so I put the little kind of DSHS alert for that. Some other kind of pictures of the way that the rash looks on the hands. And then this one is kind of desquamated already, right? So, and this is including the palms and soles. And then the CDC has a really good kind of gallery of photos. And they can really vary in appearance based on kind of the location and sort of the skin tone of the patient and the immune status. And so some of these are really subtle, like some of these just honestly kind of look a little bit like pimples, right? This one's umbilicated. You can see this one, it has very widespread. But here's a pustular phase one, and then some darkening of the palms and soles. So you can go to the CDC website and kind of look through these and sort of and be able to kind of look at the different ways that it can present. One thing that I think is really important too is talking about differential diagnosis, right? We see a lot as internists and as family medicine docs in the primary care setting, people come in and they say, I have a rash. Well, that's like such a broad term. It can be infectious, it can be non-infectious, it can be autoimmune. And so when I think about like when a patient's coming in with a rash and it might be vesicular lesions, like what's my differential diagnosis for that? And there is a pretty wide differential. Obviously, smallpox is one thing that it looks almost exactly like. That being said, it would be unusual to see that in this current kind of monkeypox outbreak, but it is different in terms of the symptom onset, timing of the rash, and the distribution. It's less severe and lower fatality rate and scarring versus smallpox. There's generalized vaccinia, disseminated zoster, there's chickenpox. Lesions are usually more superficial, they're in clusters and they're denser on the trunk. There's molluscum, eczema, herpeticum, disseminated HSV, syphilis, and then we kind of get more and more down the rabbit hole with yaws, anthrax, scabies, rickettsial pox. I have some photos here just kind of looking at the different appearance of different lesions. So this child up in the top left has smallpox, and this child in the on the right of him has generalized vaccinia. And we'll talk a little bit about that. The smallpox vaccine or vaccinia vaccine was a live virus. So many people before 1978 would get immunized against smallpox, and it would actually cause you to have a pox lesion in your arm. And there is a period of time where you could potentially spread live virus. It's modified, but if you had a patient who had immune compromised family members or something like that, it's possible to get them infected. This is a really bad case of shingles that's kind of just turned into disseminated. This picture on the top right, actually, I saw in inpatient at UHS was chickenpox, and I had never seen chickenpox before. I had chickenpox as a kid, and all my siblings were immunized, and you just don't really see a lot of chickenpox anymore, but you can tell that these lesions are different stages, right? This one's kind of scabbed over, this one's kind of opened up, and then they have these smaller vesicular lesions here. Molluscum is another differential. It can look very similar, especially with that umbilification. Eczema, herpeticum. This one on the middle and the right is syphilis. So you can look at the lesions of the palm and soles. There's some desquamation there that can be a differential. The bottom right is measles. And then these two in the middle bottom, there's drug eruption on the right. We see that a lot of times inpatient, especially on patients with antibiotics. They can have a drug rash or they can have a reaction to a lot of other medications. And then this is an eschar of rickettsial pox. So differential is pretty wide. It's good to kind of look over pictures and kind of looking at the subtler aspects of rash to sort of help you narrow down the diagnosis. But the key characteristics is they're well circumscribed, they're deep-seated, they develop that umbilication, and they're usually the same size and same stage of development on a single side of the body versus chickenpox where they'll be in like different stages. And then there's usually fever before the rash, although that may not be true about this current outbreak. So that's not a hard and fast rule. Lymphadenopathy is often present and it can be pretty pronounced. And then this disseminated rash can be centrifugal, more lesions on the extremities and the face, and it does include the palms and soles. And this rash can be pretty painful until the healing phase when it becomes really itchy. This is a good kind of differential diagnosis, putting all of that sort of in a table for you. If you wanted to like screenshot this and like keep this, but it kind of goes over some of the differential diagnosis of febrile vesicular rashes that might be confused with smallpox, which I would extend to that as monkeypox as well. And so it kind of just gives you a little bit more of sort of clues into why it could be and why it may not be. And I would say like this monkeypox, this table is out of date because monkeypox, it's not just travel to endemic area or animal exposure. It's also like sexual intimate contact, MSM population, HIV population that we're seeing too. So the diagnosis, until 2003, this wasn't really detected outside of Africa. So at that time, the CDC established case definition criteria, which has since been updated with the 2022 outbreak. The issue is like fewer healthcare providers have experience. Many of us haven't seen smallpox before, and obviously haven't seen monkeypox often, or if at all. And there are a percentage of patients that are vaccinated against smallpox. Those are generally the people before 1978. And their rash may look different. They may have a pleomorphic rash, may not be in uniform stage of development. We still just really don't know kind of the efficacy of the smallpox vaccination for monkeypox. Serum antibodies are detectable by the time lesions appear, but we're really not using that in terms of trying to diagnose it. So on the CDC website, they have discussions about case definitions, and they talk about a suspect case if you have a new characteristic rash, or you meet one of the epidemiological criteria and you have high suspicion. A probable case, if you don't kind of suspect anything else, no recent vaccination with the vaccinia virus. And then a confirmed case requires the presence of monkeypox virus DNA by PCR or next-gen sequencing of a clinical specimen, or you isolate it in culture from a clinical specimen. So that's how you come by a confirmed case. And then the epidemiological criteria, of course, we've got the travel. So if you've traveled outside of the US to a country with confirmed cases of monkeypox, or where it's endemic, or you had contact with live or dead animal. But they also in the 2022 outbreak have updated this to say if you've had close or intimate in-person contact with individuals in a social network experiencing monkeypox activity. So that includes men who have sex with men, or who meet partners through online website or digital application or app or social event, or someone who reports having contact with a person with similar appearing rash. And this is also important to know that this is within 21 days of illness onset. And then obviously exclusion criteria, if you can find an alternative diagnosis, or you can fully explain the illness, or they don't, if the individual that has symptoms consistent with monkeypox but doesn't develop a rash within 5 days, because that prodromal period, and then they should develop a rash, or there's a case where their high quality specimens don't indicate the presence of orthopox virus or monkeypox virus, or they don't have antibodies to the orthopox virus. This talks a little bit about like clinical suspicion may exist if presentation is consistent with illnesses that can be confused with monkeypox. That's where that handy dandy kind of differential diagnosis slides come in handy. And then it talks a little bit about the characteristics of the rash that can help you kind of make that diagnosis. Further, so viral culture is really only done in specialized laboratories, but oropharyngeal or nasopharyngeal swabs, they do mammalian cell cultures, but that's not going to be done. It's only in specialized laboratories. So what we're doing now is we're taking specimens from the skin lesion and we're sending it to the health department for a PCR for orthopox virus. And if that returns positive, then it goes to the CDC to specifically check for monkeypox virus. You can also see it on electron microscopy. There's immunohistochemical staining for orthopox viruses. That was developed by the CDC after 2003. And then there's serum antibodies, IgG and IgM. And then you can also check convalescent sera for specific antibodies, IgM within 5 days or IgG within 8 days. If you somehow did a skin biopsy, which hopefully you wouldn't have to do, but there's not really anything that's super slam dunk, but you could see viral inclusions in the keratinocytes. And then you might see these intracytoplasmic round to oval inclusions, kind of these sausage shaped structures. I have some pictures of that here. So, you know, you've got, this is if you somehow were able to get a skin biopsy, hopefully you wouldn't, but it might happen. But you would see these kind of virions in the cytoplasm, and he's got these dumbbell or sausage shaped cores characteristic of pox virus, and you may see it like that. So the prognosis is, we talked already a little bit about the 2 clades of the virus. West African clade is more favorable prognosis. Case fatality rate is less than 1%. Central African clade seems to be a little bit more deadlier. But patients do have it complications. They can get scarring or discoloration, but most patients recover within 4 weeks of symptom onset. But you know, basically, like how your patient does is going to be dependent on sort of their health status, their concurrent illnesses, their comorbidities, if they've been vaccinated prior or not. These are some of the complications that we can see. You know, we get really worried when patients have lesions near their eye, or they could have keratitis, they can have corneal scarring. They can also develop pneumonia or respiratory failure. If they have a lot of lesions in their mouth or kind of mucous membranes, it can disrupt them being able to take PO. They could have pain when they swallow, or if they have really widespread skin disruption, they can have insensible fluid loss, almost kind of like a burn patient. So some of these can be like pretty severe consequences of the infection. The main thing to note is that most cases are mild and they're self-limiting, and they just require supportive care, pain control, fever reducers, that sort of thing. However, some people can get severe disease. They can get hemorrhagic disease. They can have confluent lesions, sepsis, encephalitis, all those complications that we talked about, especially in immunocompromised patients. So HIV, AIDS, transplant patients, patients that are on high dose steroids, they're on biologics, those kind of things we have to be careful of. Pediatric patients, especially kids less than 8, or patients that are pregnant or breastfeeding. And if they have infection in high-risk areas, such as their eyes, their mouth, their genitals, their anus. So those are the people that we would consider kind of treating. And it's really important to note that there is no specific treatment that's approved for monkeypox. We are using smallpox treatment agents. And the main one that you're going to hear about is the tecovirimat, or TPOXX. And it's an antiviral, intracellular viral release inhibitor. And it's FDA approved for human smallpox. But we have this expanded access investigational new drug protocol, fancy term, that lets us use it outside of smallpox, but it is an ordeal. It has to be filled, you have to request it from the CDC. There's all these forms that you have to fill out to send it, and it can take some time to get the medication. And so that's kind of the main one that you should know about. There is a trial going on. We're trying to, I think we're in the process of getting approved to be in this trial, but the Stomp It trial, we're basically using TPOXX in a randomized controlled trial to see the efficacy against monkeypox. Because again, we know that it's approved for human smallpox, but not any efficacy data or data for it in monkeypox. Really, we don't really talk about using these other ones, the cidofovir, vaccinia, immunoglobulin, brencidofovir. Those really aren't the main things we're using. I don't know if you could even really get that for that indication at this time. But again, all these agents, we have its unknown efficacy against monkeypox. So we'll talk about vaccination. So orthopox viruses species, they share genetic and antigenic features. So if you have a vaccine, there's probable that you have cross protection with infection or exposure due to vaccination. And then we know that because vaccination with vaccinia virus protects you against smallpox, monkey and cowpox, and basically you get neutralizing antibody production. But we stopped smallpox vaccinations in 1978, and since then, as a population, our immunity has waned to these types of viruses. So you might be wondering yourself, or you may get asked questions about who should get the monkeypox vaccine, right? And so, you know, at the very beginning of sort of all of this, there was concern like, well, if I'm an ER doctor, or if I'm an infectious disease doctor, or if I'm a primary care doctor, like, do I need to be worried about monkeypox? I'm going to probably see it. And should I get vaccinated? But at this certain point in time, most clinicians and labs that aren't performing testing to diagnose orthopox viruses, or research lab work that are directly handling cultures, animals, and certain healthcare workers and public health people that are responding to this crisis, basically it's not, unless you're one of those people, it's not recommended to get this pre-exposure prophylaxis. Okay, so just really quickly, Jordan says, since confirmatory DNA testing gets sent to CDC for diagnosis, if a patient's positive, do they or the health department initiate coordinating treatment if needed? So as far as I am understanding, that doesn't happen sequentially. So basically, like, you would do the testing. If you had a high enough suspicion, the clinician may go ahead and get started on the paperwork for it. I don't think it specifically reflects to trying to get that going in terms of treatment, because I think very few patients actually qualify for treatment, and they're getting stricter on who would be able to be eligible to get the TPOXX treatment. And the vast majority of patients who have confirmatory testing positive don't really need it because they have very mild infection. This is from the CDC website talking about kind of the vaccination strategies used so far, and they talk about like post-exposure prophylaxis, where they recommend people who have known exposure to monkeypox get vaccinated. Expanded post-exposure prophylaxis, and that's after known or presumed exposure, and then they've got vaccination before exposure to monkeypox, and we'll talk a little bit about that, because the main thing is if you go to the San Antonio Metro Health website, they have developed these vaccine eligibility priority groups. So you can get the vaccine through the website, through the San Antonio Metro Health. We are giving it at the FACS clinic, which is our HIV clinic. And we're basically following these same eligibility groups. So obviously priority 1 are individuals that are identified through contact tracing that have been exposed. And then priority group 2 would be individuals with presumed exposure who know that they had a partner in the last 14 days was diagnosed with monkeypox, or they went to an event or venue and had high risk exposure with someone confirmed, or having sex with a partner who is showing signs like rash or sores. And then priority group 3, which is really kind of what we're seeing at the FACS clinic. So people living with HIV and people that are on PrEP for the prevention of HIV. And then men who have sex with men, who had multiple anonymous sex partners within the previous 21 days. And obviously, we kind of have to look at this in terms of our supply of vaccine has been trying to catch up with kind of the demand. So it helps to use these priority groups to help us with that. So the live vaccinia virus, which is kind of the classic smallpox vaccine, we're not using this. But I thought it would be important to let y'all know that this is kind of the classic one that a lot of people have a scar on their arm or maybe at their ankle or on their back. You got inoculated with this live vaccinia virus and you did develop a lesion at the site called the take. That can spread to other people or other sites. And so the patients need to be cautious about preventing the spread of this vaccine virus, especially to immunocompromised patients, and you're considered fully vaccinated within 28 days. The vaccine that we're currently using is this Genios one, and it's a replication defective modified vaccinia virus. So it's a 2-shot series and it's 4 weeks apart. It has a superior safety profile compared to the other smallpox vaccines, and it doesn't create a skin lesion. And it doesn't pose that risk of local disseminated disease versus the other one, the ACAM. And it's safe, it stimulates antibody production, and it can be used in patients that have atopy or immunocompromised, which immunocompromised, that's a contraindication for the live vaccinia virus. But you're not considered fully vaccinated until 2 weeks after the second dose. So it is kind of a longer period of time before you're fully vaccinated. And that's something that we have to counsel our patients for and let them know, like, hey, you need to come back for a second shot, and you're not going to be fully vaccinated until 2 weeks after that. And again, same thing, we don't really know the efficacy of this vaccine in monkeypox just yet. Post-exposure, high-risk exposure, which means contact between broken skin or mucous membranes, affected patients' bodily fluids, respiratory droplets, that warrants post-exposure vaccination as soon as possible. If you vaccinate within 4 days, you may be able to prevent disease onset, period. But within 14 days may reduce the severity. And then there's also a question of, okay, I had smallpox vaccine, and I got exposed, should I get vaccinated again? And the general guidance right now is if you have a positive exposure and it's been more than 3 years, you should consider getting revaccinated. So when you look at CDC talking about infection control, you know, a lot of times these patients may present to a primary care clinic. They could present to the ER. If you're concerned, the kind of guidance for CDC is basically like isolate the patient in a single person room with a closed door using standard contact and droplet precautions. So your PPE should have a gown, gloves, eye protection, mask. An N95 mask though, or escalation to airborne precautions, especially if high risk procedures. So if you're going to be intubating somebody or doing a bronchoscopy, it's recommended to take airborne precautions and using the N95, but you really don't need an N95 for like routine, you know, patient in the clinic and that sort of thing. And then if you happen to be exposed, let's say didn't wear the proper PPE, or you later on find out that they had monkeypox, they just recommend monitoring your temperature, symptoms twice daily for 21 days. And the infectiousness really aligns with the symptom onset. So close contacts don't need to be isolated unless, and if they don't have any symptoms. So unlike COVID, where you could have some spread prior to becoming symptomatic, this doesn't seem to be, that infectiousness seems to align more with your symptom onset. So what do you do if you are concerned about a case? The first thing you can do is report to your local hospital epidemiology or your infectious control personnel. And I did have the phone number on here. I'll have to follow up with y'all. If you're working at university hospital, we do have an infection control nurse that takes all the calls. But in general, you want to let your local hospital epidemiology infection control people know, like, hey, I've got this case, it may be this. What do y'all think? And they'll help you in terms of coordinating with the local health department. And the first thing you'll get is a kit with some swabs in it, and you're going to send that to San Antonio Metro Health for testing for orthopox virus. And then if that's positive, they send it to CDC to confirm the diagnosis. So they'll contact CDC. You want to also alert the laboratory personnel, and then the specimen collection, which I'll show y'all in the next slide, kind of the importance. This is from the CDC. If you're worried about monkeypox in a patient and you want to test them, it's really, really important. I really emphasize going to the CDC website and looking at these testing little tips for adequate collection of a lesion from a suspected monkeypox case, and that will help you in terms of being able to collect the specimen in the best way to be able to have a good specimen and can be reliable on the testing. This is available at the CDC website. And then there's also a question of, well, what do I do with this patient who are waiting for testing? Well, it's really important to let them know that if you have monkeypox, you need to isolate at home for the duration of the illness. And you can spread it from the time the symptoms start until all the symptoms have resolved, including the full healing of the rash with formation of fresh layer of skin. That typically takes like 2 to 4 weeks, so it's a long time. Patients do have to leave their house. They got to go to a doctor, or they have to go to the pharmacy to pick up medications. So in general, the guidance is if you're symptomatic with fever or any respiratory symptoms, you need to stay home, unless it's an absolute necessary, like to leave to go to the doctor or have an emergency, they have to go to the ER. If the rash is persistent, but in the absence of fever or respiratory symptoms, and they need to leave their house for any reason, they need to cover all parts of the rash and wear a well-fitting mask, and really just emphasizing to these patients, like, it's really, really important that you stay isolated. And of course, that's very difficult because isolation is a long period. So the good news for us in terms of transmission, like if it's a brief interaction in proximity for even for a longer duration, but it's brief interactions, it's really unlikely to spread it. You really need direct skin-to-skin contact, and that can include sexual or close intimate contact. And that's really the identified kind of predominant type of exposure. And most people with monkeypox have been adults and have not required hospitalization, so that's good. And deaths have occurred but are rare. So I think maybe we have 1 death in the country so far. I'm not sure the particulars about that case, but it's rare. And then we kind of just talking about the kind of association between monkeypox and HIV. So a large proportion of monkeypox cases have been in persons living with HIV. And the MMWR, there was a case series that basically looked at nearly 40% of the cases had HIV. And the outbreak, we know it's concentrated among men who have sex with men, which is a population that's already at risk for HIV, but that alone doesn't explain the high rate. So maybe related to sexual network, not necessarily HIV status, recent history of other STIs, overlapping risk factors, but we do know that HIV has an effect on the immune system. So when you look at HIV negative versus HIV co-infected patients, people living with HIV tend to have a more prolonged illness. They can have larger lesions, higher rates of complications like the secondary bacterial skin infections, skin and ulcers, that kind of thing. And then HIV patients tend to see doctors more often. So the cases are more readily identified. That can also contribute to some of those statistics, but it's really important to note that there is that association with monkeypox and HIV. This is a little bit older now, but it still stands that the daily monkeypox cases reported 7-day daily average is coming down. And it's really, yes, we have a vaccine and we're vaccinating some population. Yes, we have treatments, but that doesn't, and we have testing, but that doesn't explain that. And likely the vast majority of the reason why that we're seeing a downtrend is behavior changes. And many of my patients who have HIV or on PrEP will come to the clinic and they'll say, hey, I'm really worried about this. I'm not having sex. I really want the vaccine. And this is a group of people that have seen the HIV epidemic and has learned to advocate for themselves. And they've really kind of been sort of instrumental in help curbing this epidemic because of their behavior changes and that kind of close knit of the community. And then, it's infectious diseases aren't going away, and we're going to continue to see outbreaks of things. And the key thing on us as healthcare providers and hopefully policymakers going forward is what can we learn from each time, look at the things that were difficult for us before and learn on that. So when we look back on COVID, in early 2020, we had a hard time with developing a test. There were mistakes in design, manufacturing, and then initially it was very difficult for the FDA to let other labs use their own COVID-19 tests. And we're seeing a little bit of that in terms of like with monkeypox, it's not an easy test, right? So surveillance and size of outbreak is difficult to estimate. I will say that university hospitals working on their own in-house test, which would be a really big game changer, and hopefully other hospitals and labs across the country will be able to do that, because it does seem kind of clunky, right? The patient has to come into the healthcare provider, they have to contact the state, local health department, CDC, they've got to run the generic orthopox virus testing, and then if that's positive, then it goes to CDC. So that can create some delay in diagnosis. It can create kind of confusion of what am I supposed to do with this patient while I'm waiting for the test. And then the concern for is, am I able to get treatment faster, or those kind of things. So we have a lot of lessons that we can learn from COVID, as well as HIV epidemics, to kind of improve our response to these emerging infectious diseases. So areas for improvement, obviously the centralization of testing wastes time and it limits your capacity. And then testing based on PCR, lots of labs do PCR. We do PCR on a lot of things. If we can get these labs to be validated, we can increase testing capacity even before we really need it. And then really seeing monkeypox testing protocols from the CDC, so other labs can develop and run testing with guidance from the FDA. And then in contrast to COVID, we do have FDA approved antivirals for smallpox, and we also do have vaccines. So now is kind of a phase of we're using them, and we're now in a phase of using and doing research on them to figure out the efficacy, to kind of figure out how well these treatments and how well these vaccine works. And then we're able to kind of, from a public health standpoint, kind of tier off those vaccinations and get those going. So those are some areas that can be improved, and are already kind of improving in that sense. And so I'll take any questions or anything that anyone has.
If anybody has questions, please feel free to unmute. I didn't see any others in the chat box other than the one you answered. Okay, well, oh wait, there's another message. I almost missed it. What helps with lesion discomfort? Calamine?
Yeah, actually, I probably would say that might help. Yeah, I don't know that there's anything that's specifically for that, but I think some of the stuff you would use for chicken pox, I don't know, oatmeal bath, calamine lotion, would be helpful. I think if they have lesions in their mouth, something probably with like a lidocaine solution might help a little bit with that, especially if they have in their throat and it's a hard time for them to swallow. Yeah. Well, thank you very much. It was really nice to speak with you all, and you'll see me on the wards. I do inpatient consults and Team 6, and yeah, thank you.
Thank you so much. Thank you, Dr. Dixon, and thank you everybody for joining. I did put the link in there if we can provide some feedback, but other than that, have a great day, everybody.